So let me go ahead and introduce Dr. Bossarte. So today, for our February Grand Rounds, we are very fortunate to have Dr. Bossarte present some information to us, specifically about the Injury Control Research Center, but also maybe about some of his research interests. Dr. Bossarte is the director of the ICRC for short. He's an associate professor in the Department of Behavioral Medicine and Psychiatry within the School of Medicine at WVU. Some of his research interests include violent and suicidal behaviors, psychiatric epidemiology, substance abuse, life course, and health trajectories. So with that, Dr. Bossarte, I'll turn it over to you and let you have the floor.
Thank you. And thanks for providing the opportunity to speak to everyone today. I'm always happy to take some time to talk about what we're doing at the ICRC and perhaps find some opportunities for renewed collaboration or renewed research in any of our priority areas. Today I'm going to talk to you a lot about the epidemiology of injury and the topics that we spend our time working on here at the ICRC. And then I'll wrap up talking a little bit about some of our bigger projects and priority areas. So the title is Epidemiology of Injury and Science of Injury Prevention. I should probably say the epidemiology of injury and a little bit about the science that we're doing here. But hopefully people find it interesting. So I'll provide you a little bit of background on the Injury Center first. WVU's Injury Control Research Center is one of 10 centers funded by the Centers for Disease Control and Prevention. We receive our funding in 5-year allocations. We're currently on a 2-year supplement award, which is an unusual thing, but working towards resubmission of our 5-year proposal this August, which, if we are successful, and I hope we are, would carry us through 2023. That's 24. So our mission here at the IC is fairly broad. We do support a lot of research. About 50% of our annual budget is dedicated to funding original research, and the rest of it is used to support education, outreach, and training, which I should put in there. It also supports an administrative core, which is not listed here, and we are off-site, so it pays our rent as well. For those of you who've never had the opportunity to come by the ICRC, I invite you to come visit us. We're out on Collins Ferry Road. And in fact, I have an immersion opportunity I want to make sure everybody's aware of that I'll talk about later on for students or even interested faculty that will be happening towards the end of summer. We're driven by a community partner model. We really focus heavily on translation of findings. Knowledge translation or implementation science are 2 areas of specific interest for CDC, and all injury control research centers are required to have an outreach core. The main purpose of that outreach core is to support translation of original research and to improve practices within the community. As a CDC-funded organization or group, we are very interested in community-based programs and implementation of evidence-based programs. We're successful in successful implementation of evidence-based programs. That said, we work a lot with partners within the community. Most of our work, consistent with sort of the public health approach, is really focused on having an impact within the community and having an impact on the reducing rates of our main priority areas, which we'll talk about a little bit as well. So very quickly, thought I'd just go through a couple of quick definitions, talk a lot about the burden of injury in the United States and why we do this. I'll talk a little bit about some of our bigger priority areas, suicide, opioid overdose, like many people in West Virginia. That's something that's an intense focus for us, and there's a lot of work going on in those areas. Intimate partner violence, falls, which have a unique burden in West Virginia, traumatic brain injury, which is, of course, a priority for CDC, as well as most injury control research centers, and motor vehicle crash. Those would kind of be the big ones for us. We also have some projects in occupational environmental health, but lesser so. These would constitute the majority of the big areas for us. Just very quickly, this is sort of CDC's model. For those of you who are public healthy, you've seen this before. You know, I think it has specific interest and purpose for us. At the Injury Center, we really try to think about work along this continuum of, defining the problem, thinking about the best data we can find, thinking about how we can improve surveillance or data to inform the identification of risk and protective factors. I would like to say very quickly, I'm not a huge fan of the traditional risk and protective factor model. I don't necessarily think that's gotten us where it should. And working on a couple of projects which I hope are part of a bit of a paradigm shift there, where we move a little bit away from risk and identification of risk and protective factors as an early stage activity, and think about it more as a later stage activity, perhaps as we develop and test prevention strategies as a component of that, not necessarily as a means for targeting particular populations. And of course, assuring widespread adoption. At the Injury Center, we're involved with all of these, from the collection of injury data and thoughtful, innovative analysis of injury data, thinking about modifiable characteristics or modifiable processes that could be targeted to reduce rates of injury and violence-related morbidity and mortality, development and evaluation of new prevention strategies, and our outreach for working with our community partners and clinical and academic partners to assure widespread adoption. So that's, in a very simplistic way, our conceptual framework, although obviously the specific activities under each of those are going to be a little more complicated, a lot more complicated. There's a lot of uncertainty and lack of clarity sometimes when we talk about injury, and people say, oh, opioid overdose is an injury. How in the world is that an injury? And how did suicide find its way into injury? And why aren't we just talking about falls and motor vehicle crashes? Our definition, which is consistent with CDC's definition, is injury is anything that's external. So external cause mortality or morbidity is defined as an injury according to CDC and therefore becomes part of our mission. So opioid overdose is part of external cause and therefore one of our priority areas. We've traditionally focused on 7 different forms of injury, and they're listed here. I'll just go over them very quickly. Suicide, overdose, poisoning, intrapartner violence, falls, occupational injury, motor vehicle accidents, and traumatic brain injury. We have, though, entered a new phase in the center's development, and we began targeting a little more purposefully a more limited number of priorities. We've identified those partly based on our strengths, but also based on what we see as being a particular burden here in West Virginia and the Appalachia region, and where we might have an opportunity to make a unique contribution. And we've defined those as drug abuse/overdose prevention, suicide and childhood abuse and neglect, which is new for our portfolio and really a part of our work that is still under development as we begin to explore opportunities for a focus on childhood adversity in particular, although I refer to it as childhood abuse and neglect there, and where we might have strategic collaborations. Those of you who are familiar with the work done at the University of Pittsburgh might know a little bit about the Allegheny County data repository and the data project they have there. They've been using that a little bit to look at characteristics associated with increased risk for childhood adversity and to inform their prevention strategies and activities. We've been having some conversations with some of the faculty from Pitt about similar work here, thinking as well about those programs that have screened specifically for childhood adversity and those preventive services meant to reduce adverse outcomes associated with childhood adversity. It's a bit of coincidence. I'd like to tell you that we were very thoughtful about it, but overdose prevention, suicide, and childhood adversity were announced this year as the 3 areas of focus for the National Center for Injury Prevention and Control, which is our funding agency, our funding group within the Centers for Disease Control and Prevention. So the good news is that we have very tight overlap with NCIPC priorities, although, as you've heard, that our portfolio in some of these areas continues to develop. This is the leading causes of death in the United States for 2015. Many of you have seen these charts before. The 2016 data are out, but they haven't released this yet, at least not that I can find. And it doesn't change very much from year to year. And the blue, green, and red are specifically injury categories. They're really meant to illustrate the overwhelming burden of injury on mortality, particularly among younger adults or children and younger adults in the United States, where unintentional injury is the leading cause of death between essentially 1 in 45, and suicide is a particular contributor to middle-age mortality. Adolescents, yes, between 15 and 24, but a lot of the discussion about suicide-related mortality has been the increase among middle-aged populations over the past decade. And you can see among people 35 to 44, suicide is the 4th leading cause of death, the 5th leading cause of death among 45 to 54, and 8th leading cause of death among 55 to 64-year-olds. It's a 10th leading cause of death for all Americans, 7th leading cause of death for men. So it's a particular concern and area of focus for us. In case you're wondering, overdose falls within the unintentional mortality group or injury group. So it's included with the fourth leading cause of death there, highlighted in blue. We don't really have any programs right now that focus specifically on homicide. West Virginia's homicide rate is not disproportionate to the rest of the nation, really, although the suicide and opioid overdose rate are significantly higher. Well, obviously overdose, our rate is the highest in the country, but for suicide, we also have the 10th highest rate within the country, which for an East Coast state makes us very unusual. This is a much more colorful figure, which gives different categories of unintentional injury. And what it demonstrates, if you just kind of look at the number one row there, where unintentional injury was the leading cause of death between pretty much 1 and 45, you now see that while it is unintentional injury, the specific mechanism shifts from drowning among younger adults, not something that's particularly high here in West Virginia, to unintentional poisoning overdose among the middle-aged adults. And you can see different categories in their unintentional fire and gun injuries have a particular burden among younger adults, and then fire and gun. So it gives you a little bit of an understanding of the variability within that category. Obviously, there are a number of different ways research could go when looking at preventing some of these different causes of death. Falls, though, we'll get to in a bit, are an area of particular concern here in West Virginia, particularly for older adults in our state, which is disproportionately old. This particular figure, which looks a lot like it was developed around Christmas time, shows homicide and suicide in red and green. And you can see that the suicide is a much larger contributor to overall mortality among adolescents and adults, where firearms, in particular homicide, end up being a larger contributor among younger children. Overall, the number of people who die by suicide is markedly greater than the number of people who die by homicide each year, although obviously when you're younger and there's less mortality overall, intentional, other directed or other inflicted violence is a larger contributor among younger persons. And then just very quickly, this looks at non-fatal injury. This comes from some data provided by the CDC from something called the National Electronic Injury Surveillance System. And you can see that falls are a leading cause. Also, falls have secondary consequences such as TBI, far ahead of motor vehicle accidents for most groups, and then poisoning. Although these data are for 2015, I would suspect that the poisoning rates have gone up for 2016 once those data are available, at least in this graphical form. Certainly the rates have gone up. Why do we care? We care, well, in part because we're reducing morbidity and mortality. We also care because there's a pretty significant cost. About 2/3 of the cost from injury comes from non-fatal. So that's true for almost every category of injury that we've talked about, although obviously the case fatality rates for different forms of violence or injury and different mechanisms are going to play a factor in that. But about $214 billion a year. These were from 2013 data, but I believe they're still fairly consistent. $214 billion a year for fatal injury and $457 billion a year for non-fatal injury. If you look at fatal injuries by themselves and break them out a little bit more, you've got suicide, which costs about $50.8 billion, homicide, which costs about $26.4 billion, then unintentional injuries contributing the rest, $129.7 billion. The unintentional, again, would include opioid overdose, motor vehicle accidents, and those that we call undetermined. Non-fatal injuries, falls are the major contributor, and that's kind of reflected in that earlier chart that we looked at that showed that falls were a leading cause of non-fatal injury across the age groups, particularly among young adolescents and then into adulthood. And then the other categories, including firearm injuries at 1.3%. Being struck by against is usually someone hitting you or being hit by something, obviously. And then transportation-related injuries at 21.4%. Obviously, there's a bigger burden financially and in terms of the human cost because there are more non-fatal than are fatal, but the breakdown is obviously very different. So I thought I'd talk to you a little bit about suicide. I am a suicide researcher. It's pretty much all I do. The majority, if not all of my work, is in suicide prevention and analyses of data in support of suicide prevention, either the development of surveillance systems and using data for targeting at-risk populations. Suicide is now the 10th leading cause of death. I've already mentioned that for all ages in the United States, 7th for men. In 2016, the data just came out. There were just over 44,000, almost 45,000 actually, suicides in the United States. The rate is now 13.42 per 100,000. It continues to increase. We've seen consistent increases in the rate of suicide in the United States since 2008. Overall, the largest increases have been among people in the middle age, as I mentioned, although there have been some groups that have been identified as having disproportionate increases, particularly 10 to 14-year-old girls and middle-aged women have most recently been identified as having significant increases. And there is the long-standing at-risk population of older white men, particularly those living in rural areas. There's a bit of a space issue with the next bullet. I apologize for that, but in West Virginia, there were 362 suicides in 2016, and their age-adjusted rate in West Virginia, you can see, was 19.8 per 100,000, significantly higher than it is in the rest of the country. Just take a moment to point out that that's kind of unusual for an East Coast state. Suicide is traditionally seen as a Rocky Mountain phenomenon. Overwhelmingly, rates of suicide are highest in the Rocky Mountain region, with Colorado, Utah, Washington usually has very high rates. Alaska always has some of, if not the highest rates in the country. The Dakotas will have some high rates. Idaho, New Mexico will have high rates. So for West Virginia to show up in the top 10 or even the top 15 is pretty unusual. If I recall correctly, we are the only state in the East Coast that's in the top 15. What an interesting anecdote, and I don't include the data here, there have been some pretty significant increases in the rate of suicide in West Virginia, since 2012, which is interesting because it also marks a time of pretty rapid increase in the rate of overdose mortality in the state of West Virginia. Some of you may be thinking, does that have anything to do with the opioid crisis? The answer obviously is maybe. It's more than likely not misclassified overdoses, meaning it's probably not that overdoses were inadvertently called suicides. It's much more likely, and some of the work of Dr. Ian Rocket here has quantified that it's the degree that it's much more likely that suicides would be called overdoses than overdoses called suicides, or accidental overdoses would be called suicides. So there's something happening concurrently in the trends. Certainly gets back to some of the unique characteristics of West Virginia, some of the social, economic, environmental factors in West Virginia that may be related equally to both of these adverse outcomes. We'd just like to say a lot of the work that we've been doing here at the Injury Center recently has been trying to understand what's going on with these seemingly independent phenomena, but almost certainly related outcomes. And if you think about all three that I mentioned with childhood adversity, suicide, and opioid overdose, there's clearly commonality between them, and that's traditionally been approached by public health professionals and epidemiologists by looking for common risk factors or common protective factors, things that these three different categories of outcomes may share. But there's a different way of thinking about it, and there's a different way of thinking about it that it was advanced for some time by CDC, although they don't necessarily focus as much on it anymore. But to think about these things more as syndemics, epidemics that are driven by common social environmental factors that have synergy between them. So it's not as if the opioid crisis in West Virginia was happening in isolation from the conditions and factors that increase risk for suicide. And in fact, we're beginning to understand much more that the populations at risk for suicide frequently are populations who are also at risk for overdose and who have been misusing opioids and other substances. So we know that rather than treating these things as independent, independent events, that we begin to think about how there may be synergy between these two different phenomena, and how we may think about addressing them both analytically, to begin to quantify where there's overlap, and more importantly, perhaps, how we think about implementing programs designed to interrupt that synergy first, but reduce rates by considering the fact that developing and implementing a program designed to target a specific outcome without consideration of those other factors that are contributing to the likelihood of that outcome that may in fact appear to be something altogether unrelated are unlikely to be successful. And I will offer as a data point to support that, the Department of Veterans Affairs recently released a report looking at rates of suicide last year among patients within its healthcare system. And in that report, they broke down rates of suicide by psychiatric diagnoses or disorders, and of course those are associated with increased risk of suicide. But for the first time, they looked at the rate of suicide among persons with opioid use disorder. And what they found was that the rate of suicide among persons who have been diagnosed with opioid use disorder exceeded rates of suicide for every other psychiatric diagnostic group, including major depression and schizophrenia, which were typically associated with the highest rates of suicide. So we know that there's reason to look there. We're beginning to have a better understanding of where to look, but our work in that area certainly continues to be informed by what we're doing now and by continuing to think about different conceptual and theoretical frameworks that help us think about how we can address them. The cost, as we talked about before, is fairly significant, $51 billion in combined medical and work costs associated with suicide each year. Suicide by mechanism. I present this slide to say it's a complicated thing. Firearms account for 50% of all mortality. Among veterans in that same report, it was more than 2/3 of all suicide mortality. You really can't think about doing something about risk for suicide or risk for suicide within the community without thinking about how we tackle this very complicated problem of access to firearms. It's been a challenge. There are currently restrictions or at least considerations related to work that's federally supported around firearm suicide or that involve firearms. Certainly can be done, but certainly needs to be thoughtful. But as this graph clearly demonstrates, if you're thinking about a way to bend the curve in your rate of suicide, you're thinking about where you get the biggest return for an effective program, finding a way to do something about firearm suicide is going to be where you start, particularly when one of the few evidence-based strategies for reducing risk for suicide is controlling access to lethal means. It's been successful in the UK, where they restricted access to paracetamol. It's been successful in China, where they restricted access to pesticides, where suicide by pesticide was common. And certainly there have been things such as barriers to bridges and nets that have shown to reduce rates of suicide by jumping. So firearms presents its own particular political challenge for thinking about effective strategies. There's a movement on around increasing understanding and compliance with safe storage practices, generally considered to be a very short amount of time, and the available data suggests there's a very short amount of time between the moment when a person decides to die by suicide and that death. So the thinking is if we can give people just a momentary time to think, even if it's as little as 10 to 15 minutes, there's a chance that you may interrupt that death from suicide. So safely storing firearms or removing firearms from the home when someone's in crisis is where the field is trying to move now. By working in collaboration with gun shop owners and the firearm industry to promote what are already existing and accepted standards for storing and using firearms in support of suicide prevention. Here's a really long, complicated slide that says non-fatal suicidal thoughts and behavior are actually pretty prevalent, much more prevalent than we like to acknowledge sometimes. The first data point here is an estimated 9.3 million adults are reported having suicidal thoughts in the past year. Often these are associated with depression, but not exclusively so. The percentage of adults having serious thoughts about suicide was highest among adults aged 18 to 25. Generally speaking, there's an inverse relationship between the number of suicide attempts, the prevalence of suicide attempts in a population, and death. Adolescents, there's a ratio of suicide attempts, number of people who attempt suicide to deaths from suicide is about 20 to 1. It's about 4 to 1 among older adults. A lot of that is a function of access to firearms again. And you can see the rest of these data points. I won't bother to go through them, but they talk about just how prevalent it is. One that's worth keeping in mind is that there would be the fourth one down. The percentage of adults who made a suicide plan in the past year was higher among adults 18 to 25. We focus on that a lot because it's imminent risk, it's an indicator of imminent risk, although obviously suicide attempt is much higher. an estimated much closer to lethality, but much less prevalent. About 0.6% of the population is estimated attempted suicide in the past year, and compared to about 1.1 million who also reported making plans but not making a suicide attempt. So you can see it's a fairly low prevalence thing, although the burden is higher, particularly among older adults than that would indicate. Probably don't have to tell many of you who are on this presentation about the importance of doing something about overdose. And all of you, I'm sure, know that the United States is in the midst of an epidemic, although, frankly, I would debate that and say we're probably more in the midst of a crisis than we are an epidemic. There are some data that suggest that what we're seeing may not be as much of an epidemic as much as it is a crisis related to the availability of more potent substances. But some of these data points are, obviously, it affects all people, all ages. More than 3 out of 5 drug overdose deaths involve an opioid, and you can see all these here. Many of you probably know this information very well, that the overdose deaths from opioids quadrupled since 1999, and overdoses involving opioids have killed more than 28,000 people, or killed more than 20,000 people in 2014, and those numbers have continued to go up. Between 2015 and 2016, West Virginia's rate of opioid overdose increased by over 25%. We were already leading the nation. We're now over 50. I believe that data point is in another slide, but over 50 per 100,000. This slide shows it for the nation. The green line on top, deaths involving any opioid from 2000 to 2014, and the y-axis is deaths per 100,000 of the population. So you can see it's going up in a pretty linear fashion. But you can see the blue line there in the middle, I guess blue, kind of aqua, which is heroin, has really taken off since 2010. West Virginia, this is 2014, I apologize, it's not updated, but nothing much has changed other than the numbers have gotten bigger. West Virginia stands out in the rate of opioid overdose among the rest of the states in the United States. Here's some West Virginia specific data for you. Many of you have probably seen this, some of you have not. It's useful to reflect on how it may be similar or dissimilar from the U.S. trend. You can see an overall increase from 2001 to 2012, excuse me, where the rate of overall overdoses, all substances, began to decrease a little bit. 2012 was also when the PDMP was implemented, or at least changes in use of PDMP were implemented here in West Virginia. So you can see a decrease. What is perhaps more troubling is an increase in heroin and fentanyl-related overdoses that you see occurring about that same time. And certainly the comment I made earlier about the potency of the substance being used, clearly heroin and fentanyl can be much more potent than prescription opioids, and therefore carry a higher fatality risk associated with use or misuse. So exactly what's driving the changes in the rates, and whether it's an increasing population at risk or an increasing lethality of the substance being used, I suppose is something that merits further consideration, and something that we're looking at here with some of our work, both independent and some work that we're doing along with SAMHSA. Just another slide to really demonstrate taking data from SAMHSA, their National Survey on Drug Use and Health, showing the overdose deaths kind of spiking, not just for us, but for the rest of the nation, and the percent change among these groups. It clearly demonstrates that 18 to 25-year-olds, where there have been a 109% increase, and 26 or older is where a lot of the change is occurring. Non-Hispanic white, and obviously there's been a focus on increased morbidity and mortality from overdose in rural areas, and a pattern that we also see along with suicide risk. Intimate partner violence is also an area that we do a fair amount of work in. I'll describe a work group that we're doing as part of an international collaboration here in a bit, using data to look at intimate partner violence. It's something that West Virginia also has a higher than, a comparatively higher rate of intimate partner violence, including murder followed by suicide, where West Virginia's rate, the last time that the data were available, was roughly twice as high as would be expected based on national data. It's very prevalent. It estimated 31.5% of adult women have been victims, if not more. Obviously, some estimates of that are significantly higher. but safely, at least a third of women have been victims of IPD, and an estimated 22.3% of women have experienced at least one act of severe physical violence by an intimate partner during their lifetime. So it's prevalent. It affects all age groups, although as this first slide shows, by category of violence, forced sexual intercourse, stalking, or physical violence, the age of first victimization varies by type of violence, with forced sexual intercourse overwhelmingly occurring before the age of 18, stalking and intimate partner violence respectively occurring more frequently as women age, with stalking more heavily within 18 to 24, 25, 34-year-old age groups, and intimate partner violence much more likely to occur during the years 18 to 24. Would like to point out that some of the work that's been supported by the ICRC has also looked at sexual violence, excuse me, perpetrated against males, where there's also violence and victimization, putting aside for a moment reciprocal violence or violence within relationships that may be bidirectional. There's also male victimization. Same roughly, but not really, age-based patterns happen here. I guess the important part of this slide is that there are clearly age-based differences in the type of violence, although very importantly, the characteristics of sexual violence are very different when looking at these categories for men and women. But again, looking at opportunities for prevention, focusing on people younger than 24 years of age, particularly among men, where both men and women have a higher prevalence of first experience with intimate partner violence. Falls are a particular concern for West Virginia, not only because of the morbidity and mortality associated with falls, but because of the unique characteristics of West Virginia and the fact that we are aging as a state in a way that's disproportionate with national trends. The problems of falls are the fall themselves, of course, but the secondary injuries such as traumatic brain injury, which turns out to be a significant problem. It's highly prevalent. Each year, more than 2.8 million older adults are treated in emergency departments for falls. Over 800,000 each year are treated for hip injuries, or 300,000, I'm sorry. 800,000 for a head injury or for a hip injury. More than 95% of hip fractures are caused by falling, almost always by falling sideways, and falls are the most common cause of traumatic brain injuries. And I guess in a pattern you see with a lot of injuries, falling once more than doubles your chances of another fall. Because I like graphs, I put a graph in similar to what you saw with overdoses. You see rates of unintentional fall death among older adults have been increasing really dramatically since 2005. Those increases, by the way, have continued. If we look at all forms of injury-related mortality in West Virginia, falls had the greatest growth in rates over the past 5 years. While it's not specifically one of our top 3 priority areas right now, it is an area that it remains of intense focus and concentration for us. The challenge for us has been simply people who are willing to work in this area. Gina Jones has been a long-time ICRC affiliate investigator and certainly has done a tremendous amount of work for the Injury Center and for the state of West Virginia in this area, but we don't have a lot of other people who are interested. So if anybody out there is listening is interested and would like to discuss some potential research projects in this area, we welcome those conversations. This is a fall-related mortality rate for everyone, all ages in West Virginia between 1999 and 2014, and it shows pretty clearly that it's been increasing from a crude rate of just over 6 in 1999 to just over 14, just under 15 by 2014. But if you switch that to older adults, this being age 65 years and older, you can see it's gone from under 35, I think it's 33.6 if I remember correctly, to just under 75 per 100,000. So it's more than doubled in the past 15 years. And that trend is expected to continue. The 2015 and 16 data again showed increases in the fall-related mortality rate among older adults in West Virginia. Motor vehicle crash, can't stop this conversation about existing priority areas, even if this is a secondary priority, of course, right now. without talking about motor vehicle crash. In contrast to other adverse outcomes, motor vehicle crash rates have been decreasing in the United States over the past decade, which is why for us right now it's a secondary priority, although we have seen some increases in motor vehicle crash, and there are some particular characteristics of motor vehicle injuries in West Virginia and other rural areas that are unique, such as ATV-related injuries, which Jim Homecamp used to study here when he was part of our injury center. They're worth continued consideration for the state of West Virginia and the surrounding region. But U.S. crash rates did fall. What's interesting is they haven't fallen as much as they have in other high-income countries. The second bullet point points out that U.S. crash deaths fell by 31% between 2000 and 2013, but they fell by 56% in 19 other comparison countries, other similar high-income developed countries. And the last bullet point makes the point that over 18,000 additional lives would be saved if U.S. crash death rates equal that of the average of the other 19 high-income countries, meaning we can do better. The cost is high, about $300 million in direct medical costs. They're largely preventable. The major risk factor is not using seatbelts, car seats, or booster seats, and they contribute over 9,500 crash deaths. And of course, driving while impaired or drunk driving with 10,000 crash deaths. And of course, there's also been concern about driving while impaired while using other substances and opioids, and some of the work that's been coming out of states where they've legalized marijuana, looking at the impact that has had on crash rates. And then of course, excess speed, which is almost universally a risk factor. The last area that I'll touch on before talking about some research for just a couple minutes is traumatic brain injury. Estimated 1.7 million people sustain a TBI annually. Any of you who watch the NFL or have heard about the CTE probably knows a lot about TBIs and the long-term consequences of TBIs, even if the etiology is not clear or the mechanism, the criteria we use to define a TBI are still under debate. The consequences of TBI are not. Of the 1.7 million people who sustain a TBI, each year 52,000 of them die, 275,000 are hospitalized, and nearly 1.4 million are treated and released from the emergency department. So we know that the individual and social cost of TBI is high. It's a contributing factor to a third of all injury-related deaths in the United States. About 75% of TBIs that occur each year are concussions or other forms of mild traumatic brain injury, where there is now evidence that it's the repeated insult to the brain that's associated with increased risk for severe outcomes like CTE rather than major injury to the brain. The costs are high. In every age group, TBI rates are higher for males than for females. My standard comment there is because we traditionally do the dumber things. It's just evolution. Males still do dumber things. Males age 0 to 4 have the highest rates of TBI-related injury, department visits, hospitalizations, and deaths. I thought I'd leave the TBI stuff there. So in the 5 minutes I think I have left to talk, I thought I'd just go over some of our bigger projects, give everyone an idea of what we're doing. I would like to say we're currently preparing our submission for the fall for our next 5 years of funding. 56% of our budget will go, or roughly $430,000 a year, will go to support original research each year. If anyone has an interest in any of these topics or interested in collaboration in these topics, please feel free to reach out to me. I'd be happy to talk to you more about what we're thinking. In addition to the research projects that will be proposed as part of our core funding, we will also, if successfully funded again, have what's called an exploratory research program, which will give smaller awards primarily to internal or some external partners. Those do not have to be announced as part of or submitted as part of the proposal, but will be determined each year as we move forward. So it's essentially pilot funds. So some of the major activities that we've been included in, working on over the past several years are overdose prevention, obviously. Herb Lynn, when he's still with the center and he's still working with the center, is working on naloxone distribution. Robin Fellini, who joined us last year, is continuing that line of work, as well as expanding her work with development and support for harm reduction programs, including naloxone distribution to injection drug using populations. One of our PhD students, Kara Stokes, is wrapping up her dissertation, working on data that was analyzed in collaboration with World Mental Health Survey Initiative, using data from 6 countries who administered nationally or regionally representative surveys and collected couples data on marital violence and looking at the predictors of marital violence. Prediction of suicide risk, we're doing a fair amount of work in this area. This is our foray into machine learning, predictive analytics, using large clinical and social environmental data to predict risk for suicide. The idea behind these initiatives are to develop risk stratified or population level stratifiers so that instead of identifying people based on risk factors, we identify people based on their predicted risk score and then work to identify modifiable factors, what we traditionally consider risk protective factors, to reduce risk once the person has been identified. This work started with something called the U.S. Army STARS project, which is a large Department of Defense funded suicide prevention research project. It was continued by the Department of Veterans Affairs. The Department of Veterans Affairs is currently, has over the past year, implemented an outreach and intervention strategy based on predicted risk. So what is happening in VA now, among their roughly 6 million people who get care from the VA, each month, every patient in that system has a suicide risk score calculated. And for anyone who falls within the top tier predicted risk, an intervention is initiated, including comprehensive case review for polypharmacy, some safety planning, discussion of firearm access within the home, and strategies for reducing risk when a person is in crisis, and just other ways of letting the individual know that services are available, what's called caring communication. That has not yet been adopted by other health systems that I'm aware of, although interest in that work is continuing. We are working with the Department of Veterans Affairs on development of a new model, as well as working with Uniformed Services University of Health Sciences, which happens to be the home to the STARS project, on comparable work, not necessarily predictive analytics for suicide prevention in that project, but other work that looks at risk for suicide among military populations, with the idea of transporting those projects to academic settings, including here at West Virginia University, where we're proposing a new project that's in line with these two. Now, fall prevention among older adults, the work of Dina Jones has been critical for the center in that area. Characteristics and prediction of opioid overdose, in the very same way that we're looking at how we can identify people at risk for an event without waiting for those risk factors to be identified or to emerge. We're working with VA data, the advantage there being that they have an extraordinarily large patient population, and they link all of their data to mortality data, so you not only have information on the cause of death, but you have information on their clinical characteristics for however long they've been in that system that could be used to generate these predictive models. And this is actually the dissertation topic of another one of our graduate students who's working with VA in support of that project and leadership of that project, Sarah Warfield, who's doing that with us. And then the development and implementation of community toolkits to support stigma reduction associated with opioid use. This work is being led by one of our affiliates, who's a specialist in health communication, looking at the development and dissemination evaluation of the toolkit, which is a media and communications toolkit, working with communities to implement and evaluate their own stigma reduction media and education campaigns, using the available evidence from the fields of health communication and communication in general, but just a little bit of marketing thrown in. We look at the long-term effects or short-term effects of these sorts of public education and mass media strategies. That is it. Those are my slides. So happy to answer any questions if anybody has them.
Can you hear me?
I can now, yes.
Okay, I was on mute a couple of times, so I had to make sure. I've unmuted everyone else's phones, and so if you do have a question, feel free to go ahead and state your question. While people are thinking about their questions, obviously the traumatic brain injury area is a direct, one area where the two centers overlap, and so I appreciate you noting that. I think maybe sitting down to discuss the different approaches. That particular program, we just finished with the webinar, and that there's a federal and a state side, and the federal one, application has just come out. So there's an opportunity there to incorporate partnerships as well as your cycle of funding for the ICRC. So that would be good.
That'd be great. That's an area where we are developing. I wouldn't say it's one of our investigator strengths.
Okay.
So an area where collaboration would be of particular benefit.
Okay. That would be great. And of course, you mentioned a lot about opioid, and that's a huge issue for our state. I think we are developing, and I'll follow up with you about this, we're developing a panel discussion, and I know another one is coming up during the Festival of Ideas, the week of that. So our director of the AUCD is coming in for a visit, and we're trying to get a panel event to discuss about opioid use among individuals with disabilities, specifically. Yeah. You might have seen a comment period go out from NIH about that, so we think that maybe grants are coming out afterwards. So to get that conversation started might be good, and I'll follow up with you to see if you would have an interest or availability there.
Yeah, absolutely.
Great, I appreciate that. We'll just pull you into all kinds of different areas.
But likewise, yeah. I should let you know as well as everybody else know, I'm headed to DC next week, and the ICRCs are sponsoring a congressional briefing, which I'm sure will be attended by any number of staffers, not necessarily our representatives, but just specifically on this topic and how the injury centers are contributing to the solution to the opioid crisis. So I'd be happy to sit down with you as well before I go to sort of let you know what we're covering and maybe even what some of the other centers are doing, because as the sort of injury center collective, we're not only trying to find opportunities to support our local collaboration, but if we can help foster collaborations with some of these other centers who may also have work going on that aligns really well with what you're doing that may not be our particular strength here. Happy to make those connections as well.
Well, thank you. Likewise. Likewise. Hey, I'm looking at the chat. Anyone have any other questions? All right, I know that there's been several chats for me about whether this is being taped so that they could review it and consider it in more deeper level. So I appreciate your time. And it is nice. This is the first of many steps to get the two centers working together. So thank you very much.
Thank you for the opportunity.
All right. Well, take care.
You too.